My guest today is Professor Piyush Agarwal, who is Professor of Surgery and Urology and Director of the Bladder Cancer Program at the University of Chicago. His clinical and laboratory research focuses on bladder cancer, the urinary microbiome, molecular targeted therapy, and immunotherapy. Welcome, Piyush.
Thank you, Gil. Thank you so much for the invitation. I appreciate it.
Yeah, thanks for doing this. So we have a number of different topics we would like to get into. I want to start with, you said that aging of the population with greater need for urologists, strain on the healthcare system as greater need for surgeries in older population, leading to more intervention and more hospitalization. And urology is a specialty that relies on new technology. Clearly, except for a few countries, every country is aging, unfortunately. And along with age, I guess urology-related issues happen, and there is a significant surgical intervention there too, right? So from a U.S. perspective, so what is happening? Do we have enough specialists in this area, or are we lacking specialists?
Gil, when I applied to urology, there were only about a little bit over 200 spots in the country each year. And the match rate my year was about 30 to 40%. So, you had basically, 600 some people apply and only about 200 or so match. So it was quite competitive. And the spots have now increased. There's about a little bit over 400 some spots. And the match rate for last year was 83%. So despite the spots going up significantly, the applications did not go up proportionately. And the problem is that the average urologist is in their 40s and 50s right now, the average practicing urologist. So by 2035, most of these urologists will start entering retirement. And as the population continues to age, along with the urologists aging themselves, and without the applications going up significantly, and the spots, we haven't increased the spots that dramatically, there's a fear that we will get in a situation where there may not be enough urologists to serve the United States. There's some other factors that go into that as well. Most urologists are in urban areas, and most of the needs of the patients are in the rural areas. So the average patient has to drive more than 30 minutes to see a urologist. There isn't one just around the corner. So if you live in, average America, if you live kind of in, rural America, and those are the patients that really have a need for urologic services. So it's a problem that, I worry about, from a policy perspective, even though I, focus in a small area, but I worry about my specialty, and I wonder if it's a problem in urology, whether this is a problem in other medical specialties as well.
Yeah, that's a really interesting point. So I wonder strategically, we know that everybody is aging, so there are certain disease areas that's going to have a higher demand, right?
Right.
You can think about neurology, you can maybe think about diabetology and urology. But are we really sort of strategically thinking about this in terms of capacity and demand for these specialties?
I don't think we are, to be honest with you. I think basically, everybody is focused on the here and now. And, our governing body, the American Urologic Association, has basically, they're in tight control of these spots for urologists. And it, in my mind, has not expanded to the degree that it should. Now, part of that is because it's a competitive specialty. Overall, it pays pretty well. And most urologists are very busy and active. And one of the fears is if you if you open the floodgates, you may not enjoy the prosperity and the volume that you currently enjoy. So that is a situation, and I think in primary care they've acknowledged that there's a to serve the rural community. So there are incentives to practice in a rural environment, you know, pay back your student loans and programs, you know, certain residencies, so that you will, because later you're going to, you know, provide, you know, state-of-the-art care in a rural environment. But, you know, urologists as specialists, we haven't done that. We've increased the spots slightly, but we have not pressured people to go work in rural environments. We've not pressured people to work in, you know, parts of urology. For example, infertility is really, you don't deal with older patients, you deal with young patients trying to have children. We have not pressured people to go into, you know, geriatric urology, which is not even a subspecialty, but it should be. But we've not pressured people to go into those typical problems of urinary incontinence or an enlarged prostate or recurrent urinary infections, or neurogenic bladder where people cannot void properly, which typically are problems that happen in older patients. We have not pressured our trainees to go into that area of urology, and frankly, because there's been no incentive to do that. You can't generate, you know, money doing those procedures as much as you can by removing prostates from people who have prostate cancer. So I just think our organization and our specialty is not preparing for the future when, you know, there's going to be a great demand and very few urologists who are kind of providing that care and are mostly centered in urban environments.
What's the situation worldwide? Is this a US phenomenon, or do we have sufficient, you know, sort of demand capacity balance elsewhere?
Yeah, so worldwide, there seems to be, you know, a good number of urologists in other countries, and part of that I think is because of the training. So in a lot of other countries, what happens is everybody sort of gets a surgical training. And then after a surgical training, during their surgical training, they actually are rotating on the different subspecialties such as neurosurgery, orthopedic surgery, and urology. I mean, in India, this is very common, for example. And then what will end up happening is then they have to pick a subspecialty in the middle of their surgical training. So the urologists get a very, you could argue that some of their initial training may not be focused to urology, but they develop a skill set of just doing surgery. And I would argue that a lot of the international urologists are very skilled technically because they have been taught to be surgeons before being urologists, whereas in the US, a lot of the programs used to do 2 years of surgical training before going on to do urology specific training. And now many of the programs have limited that surgical training to about 3 to 4 months of surgical training, and everything else is urologic training. Now, the trainees are learning how to do surgery when they're in urology, but it's very urology specific surgery. And for example, when I was a trainee, I did 2 years of general surgery. I did transplant surgery, I did vascular surgery, and those techniques, you know, have stayed with me in my urology training, and they've helped me become a better surgeon urologically because I remember the, you know, the concepts and the techniques. And not to say that our current trainees are not well trained, but I think, you know, the problem is that there's no exposure to urology unless you know about it up front. Whereas in the other countries, somebody can just go into surgery and have an equal chance of being a neurosurgeon or a urologist because they're going to be exposed to everything. But here in the US, unless you know when you're a third-year medical student that you want to do urology, it's very hard to kind of go into it unless you know. And honestly, as a medical student, you don't get a lot of exposure.
That's really interesting. So it's sort of an educational system design question. Should there be sort of foundational areas like surgery, diagnostics, and so on, that is sort of your early part of your education, and then you specialize in specific areas. So those foundational skills then gives you a lot of breadth in terms of thinking about the problem, right? And it seems like that is what's happening outside the US, but that's not happening in the US.
Yeah, I mean, for example, so the first exposure to urology is usually on a surgery rotation. And so usually in the third year of medical school, medical students have to do rotations on different services. And since urology is a subspecialty of surgery, what most programs will do, so for example, here at the University of Chicago, where I'm at, the medical students will do 6 weeks of surgery rotation, and then they'll spend another 4 to 6 weeks doing electives, and they're not automatically assigned to do urology. So if they're not assigned to do urology, they may never know about the specialty unless they take the effort to go back later and do a rotation in urology. There's also differences in exposure to urology based on where you're at. So for example, I went to Cornell Medical School, which has one of the top urology departments in the country. So everybody gets exposed to urology because it's such a famous department. But you may end up going to a medical school in Pittsburgh or in Philadelphia that doesn't have a big urology department. And if you go to one of these smaller hospitals in Philadelphia, is a good example. There's, the small training program called Allegheny General, which has a relatively young, small urology program. And those students, unless they go out of their way to go rotate at Temple or Fox Chase or University of Pennsylvania or Jefferson, they're not going to get a good urology experience. And those medical schools are going to graduate fewer trainees that go into urology. So a lot of it is, whether the existing medical school has a urology program, whether the program is held in high esteem, and whether that department interacts with students, and whether rotations are required in urology during their surgery rotations. And there's a lot of variability across medical schools. And that's the problem. It's really being at the right place at the right time. I went to Cornell, I was exposed to it, and I loved it. But if I went to another medical school, it's possible I would have never been exposed to it, and possible I never would have gone into urology.
So I want to ask you a basic question, Piyush. So how is urology specialization related to OBGYN specialization, or is it?
Yeah, very interesting. So, OBGYN a long time ago kind of became their own residency. So if I remember correctly, I think historically they also did this training where they did surgery first, like general surgery, rotated as general surgery residents, and then later went into OBGYN. And then, throughout my training, it's always been its own residency at every institution I've ever been at. And I would say it's got its pros and it's got its cons. I think the cons are that, again, you only learn site-specific surgery. So for example, if you are operating to remove a uterus for uterine cancer and you get a bad injury to a blood vessel, you may only know how to kind of repair that blood vessel or manage that blood vessel related to the uterus. But the inferior vena cava, which is not, it's not too far away, is a big vessel. And if you were to injure that, that could be very difficult to manage. And if you don't have good training, you could potentially get into a really difficult situation. So, I have my personal opinion, which is I think anybody who does surgery in the abdomen should rotate through general surgery. But, you could argue that OBGYN has been doing it for years without that and has done a fine job training its trainees. We in urology do rotate through general surgery, but as I mentioned, many programs now have limited that exposure. So we are going to see how urology does, because we are now adopting that model of OBGYN where we're just going to train our surgeons within our own discipline. But I trained with general surgery, and I really value that training, and I think I'm a better surgeon as a result. But what is probably going to happen is those, as you know, OBGYN, you can be, just like urology, you can be very office-based and you can not be in the operating room as much, or you can be in the operating room all the time doing bigger surgeries. And I think what will happen is those residents in both specialties who want to be in the operating room and do complex surgeries are going to go on and do fellowships afterwards for that additional training. And I think that those that are going to be office-based are going to realize that their skill set is probably not in the operating room, and they're going to take on the less challenging surgical cases and do more office-based practice, which is very feasible in both specialties.
You touched on this before, sort of the disparity between urban and rural care. And in specialties, I would imagine, like urology and others, where there is a demand capacity problem, I guess the rural areas are even worse affected, right? Like you mentioned, people have to travel 30 miles to go see a specialist. So from a policy perspective, what do you think is the solution for something like this?
Yeah, it's a tough situation. I can tell you that we at the University of Chicago, for example, we see a lot of patients from rural areas in Northwest Indiana, because Northwest Indiana is in between Indianapolis and Chicago. And unfortunately, there's really no major medical center there. So when they get afflicted with bad disease, they have to drive. And a lot of the urologists available in these areas are older. They're general urologists. They're not specialized. So when patients need more advanced care, those patients get referred either to Indianapolis or to Chicago. And we're the beneficiaries of that because we are the nearest academic center to Northwest Indiana. And I think right now the current solution is referral to tertiary centers. And for example, what I do is a partnership with the rural urologist. So I basically, patients will get sent to me. They'll get all of their imaging, all of their workup for complex cancer locally. And then they will come to me for one visit to review their images, talk to them about surgery. And the next time I see them, I do their surgery. And after that, then all of their follow-up is done locally by their rural urologist, who communicates with me. And if anything pops up, then they come back to me. So we sort of share the care of the patient. And I have a relationship as a tertiary urologist with several general urologists. And that's, I think, the current solution. Now, I don't know if that's sustainable. I think that, if I were designing policy, I would want to incentivize my, urologists to go out to the rural areas. Now, the problem is we have a lot of technology in urology. We use the robotic surgery very often, and you're not going to be able, a rural hospital is not going to be able to buy that for a urologist. So, so a lot of the urologists coming out of training, they either want to be very technologically savvy and do very complex cases. And unfortunately, right now, the only place to do that is in a major academic center. But there have to be some incentives to go work in a rural environment, possibly salary, possibly loan repayment. Quality of life is better in a rural environment. So that's a potential way to lure people to those environments. And a current solution is actually locum tenens. So urology is becoming a very popular area where urologists who are older or who have flexible academic practices will go to a rural health system on the weekends or a few days of the week, and they will provide care there. They're paid very well by the rural hospitals to go there for a couple of days, a couple of weeks at a time, and provide care there. But they don't live there. And so they come in there, provide some shift work essentially, and then come back. And that's a solution for some rural programs. But again, there's no great solution here. But there are some emerging solutions which I think are working currently, but still the average patient is still traveling quite a bit and is having to go to big major academic centers when they have significant problems.
Yeah, I mean, it's a really interesting thing because if you look forward and you say there's a lot of technology, there's robotics, there's artificial intelligence, that sort of points to centralization because you cannot have distributed, high-level technology. So there's been a lot of talk about sort of medical tourism and things like that. So I wondered if you're heading to a regime where you're going to have few mega facilities with all the technologies in the world, and that's able to take in a very large number of patients, provided they can get there. The transportation problem has to be solved. But from an efficiency perspective, that appears to be not a bad solution.
It's not a bad solution. And in fact, in Europe, they've adopted the tertiary model very well. So they basically have a bunch of rural or community urologists that will diagnose a problem and then refer the patients to the major academic centers for the bigger surgeries. And it works quite well. And in fact, in Europe, the training is half the time for the community urologists and longer for the academic urologists. And so the trainees make the decision what they want to do, and they do that, and their training is adjusted accordingly. And salaries, I don't know about salaries, but I think the salaries are higher at the academic centers, but so is the cost of living, and the training is longer, whereas training is shorter for the more community urologists. The costs are lower, they get paid, a little bit lower, but again, because of cost of living, it probably evens out. And that tends to work well kind of in that system. We are the beneficiaries in this sort of tertiary model when you're in the academic center. And a lot of academic centers, I'll give you Cleveland Clinic and Mayo Clinic as examples. What they've done is they have a main mothership hospital, if you will, and then they end up buying all of these satellite facilities, and they have either community urologists that they've now employed as part of their system, or they actually have some of their own urologists that they've sent out there who will see the patients in their local environment, and when they have a significant problem, then refer the patient to the main hospital for the big treatment. And now there are van services and other transport companies that will transport patients to and from their appointments. So I think that is going to be the model, because it's really hard, I think, to get your average urologist to want to take a job in a rural environment. Most people want to live in a city or near a big city.
Yeah, I'm thinking even diagnostics, Piyush. So in the community setting, office-based practices, if we are sort of moving toward artificial intelligence, AI-assisted human diagnostics, and that information is easily transmissible. You don't necessarily need to go to a community practice to do that, right?
Right.
So it almost seems to me that it's sort of a binary outcome. Either we're going to get people to go practice in the community settings, or we're going to have very high levels of centralization. Where do you think we'll end up, if you look forward 5-10 years?
I would say it's probably the latter. I think you're right. I think we might be leveraging technologies like AI, where we might put a patient in front, of a Watson type device where they plug in their symptoms, and then certain diagnostic tests are recommended. They get that at a local radiology center, and then a telehealth appointment will be set up with somebody at a tertiary facility. So we are doing a lot of, the pandemic, the only good thing I could think that's come out of the pandemic is that we as physicians now can legally do telemedicine. And I can't tell you, I'm really surprised at how many patients I have only met through a video visit like we're having now. And the next time I see them is when I'm doing their surgery. So they basically, without meeting me in person, shaking my hand, and they are willing to just come to me for surgery. And I think that's probably what's going to happen, is that I can reach out to the rural patient, provided that they have some local imaging center to get the things I need in order to work them up to come in and get their surgery. In fact, in the University of Virginia has a pilot program. So most of Virginia is actually very rural, and outside of the big cities like Charlottesville and Richmond, and then the area near DC, the rest of Virginia is pretty rural. So University of Virginia piloted a program where they taught physician assistants who are in the rural areas, because they can't even get doctors to go out to the rural areas. None of the doctors want to live there. So they taught physician assistants how to do a procedure called cystoscopy, where we look inside the bladders for patients. And they sent the people out there, the physician assistants, to go do cystoscopy on patients who had blood in the urine. And then they would record the images and send it over to a urologist. Urologist would train them. And anything that looked abnormal, then those patients were referred for further care to UVA. And in this pilot program, it worked out quite well. The patients had high satisfaction. There was really very few cancers and abnormalities that were missed. And physician assistants enjoyed, doing the procedures and having the supervision. And the doctors were able to extend their reach without actually traveling to the rural environment. So I think, and that was before telemedicine. So now that's actually more of a reality now. In fact, I have trained my own physician assistant how to do cystoscopies, and we do them together. But in time, he probably could function independently of me. And so using these allied healthcare providers, we call them advanced practitioners. Sometimes we call them mid-level providers, but I know they don't like that term, because that mid-level diminishes kind of their importance, because they're quite important to the team. But these advanced practitioners who are not physicians can really extend our reach into these rural environments. So I think that is also going to be part of this AI revolution, this expansion of the tertiary centers with rural satellites. I think this is going to be probably the way we'll practice medicine in the future.
Yeah, sort of a hub and spoke system. Yeah, this is actually a good model for the developing countries too, I would imagine, if you implement it systematically, right?
Right, absolutely. I think you just cannot have high-tech equipment and facilities in every corner of a country. And when I think of a place like Mumbai and other places in the world, I can only imagine that without the system, you would not be able to provide care, everywhere. Other countries have kind of a public and private system, and that's another issue, because there's different levels of care there. We usually, I would say, throughout America, you really will get pretty good care at most institutions, and in most of the community hospitals, if they can't do anything complicated, they usually refer them or transfer them to bigger hospitals. So but I think this hub and spokes system is, I think something that definitely could be applied worldwide and would make up for a specialty where there are very few specialists.
Right. So I want to go into one of your specialties, that's prostate cancer. Um, so neurosurgical movement regarding prostate cancer. So this is prostate is something that older men gets into, right? Not cancer, but sort of an enlarged prostate. What is sort of the incidence rate of prostate cancer?
Yeah, so prostate cancer is the most common cancer in men, and it is one of those cancers that is in the history of prostate cancer is that it used to be a very difficult, challenging operation, and used to have a lot of morbidity and death, blood loss, rectal injuries. And for a while, we as urologists would never do them. Then there was a rush of other treatments like radiation therapy, which had its own side effects as well. And then there were refinements in the technique that allowed us to do a more precise surgery, and we were able to do a more precise surgical removal of the prostate. We minimized the blood loss, the rectal injuries. We still had to deal with incontinence and erectile dysfunction as side effects, and we still deal with them today. But our techniques have gotten a little bit better. And now with robotic surgery, now even those people who were gun shy about doing this challenging operation, this has made the operation a lot more easy, and a lot more easy on the patient as well as easy on the surgeon. The problem with all of this revolution was we forgot to ask the question, do we have to operate on everybody? And we now have come forward and answered that question. We realize that we do not need to operate on everyone, that not all cancer of the prostate has to be treated, because many of these men will develop cancer while they're older, and they will live to die of something else other than the prostate cancer. And a lot of this happened when the U.S. Preventive Task Force made a recommendation that prostate cancer should not be screened for. And it was a really controversial opinion, and it really, really changed the way we as a specialty kind of looked at prostate cancer. And we were on the defensive. We were forced to look at, who do we offer the surgery to? What are the risk factors? In fact, one of my colleagues is on a personal mission to redefine early prostate cancer as not being cancer at all, because in his opinion, when you have this early prostate cancer, patients will want to seek treatment, even though the physicians will tell them you don't need it. They can't live with the idea of having cancer, and they end up getting a treatment that may not be necessary because they will probably die of something other than prostate cancer. So this revolution in prostate cancer surgery and treatment forced us as urologists to reassess ourselves, to realize that we overtreat patients. And now, I think we have made a lot of changes, and now we actively practice something called active surveillance, where if somebody has prostate cancer, we will follow them with biopsies and MRI and their blood test, the PSA, and very carefully follow them and wait for a trigger point to do surgery or to do radiation. So 20 years ago, we were not doing active surveillance. We were not doing, robotic surgery. We were just kind of, removing prostates because that's what we knew how to do as urologists. And if you were a man and you had a prostate, well, then you would eventually see a urologist. But I think now you're seeing the urologist, but you're having a very informed discussion about the risks and the benefits of screening. So now if you're above the age of 75, we don't even look for prostate cancer, because the assumption is you'll probably have it, and that it will probably be a low-grade cancer that you won't die of. And that's sometimes a difficult conversation to have with a patient, because obviously a patient comes in and says, this is America, I want everything done. Why are you not checking me for prostate cancer? We have to have this discussion that, there's good data to show that you probably don't have a cancer that is something that you're going to die of. But that strategy can also miss some really aggressive prostate cancers that, albeit rare, can occur. So it's not a perfect approach, but we have kind of been on one end of the pendulum, and we are now trying to kind of regress to what we think is the optimal mean of the way we should practice.
Are the diagnostic techniques improving? So with a biopsy, could you tell if it's an aggressive form or sort of slow developing?
Absolutely. I mean, a lot is happening in this area. So I used to be at the National Cancer Institute, and one of my colleagues, Peter Pinto, and among other people in the country, it's not just him, but the use of MRI technology has really kind of changed how we do biopsies for prostate cancer. It allows us to now image the prostate and find suspicious areas, and we can grade those areas at how suspicious they are, and we can target specifically those areas by taking those MRI images and fusing them onto an ultrasound platform to then do biopsies. And when I was a resident, we would just have an ultrasound image of the prostate, and we would take basically 3 biopsies laterally on one side of the prostate, and then 3 biopsies medially. And they were kind of at different points in the prostate, but there was no systematic way of really doing it, and there was a lot of variability in operating error. Now, we use images of the MRI, we can do a more precise biopsy, adopting maternity leave, adopting time off during training and work to help raise the family, incorporating resources to allow women to be surgeons and yet have the resources to raise their kids, to have schooling nearby, to have childcare. A lot of programs are becoming more and more sensitive to it. So I think it's moving in a positive direction. And again, along these lines, after the George Floyd incident, a lot of push has been made for diversity and inclusion. So it's not just a problem with women in, holding key academic roles. It's also in people of color and minorities not being able to hold those roles. And so there's been a good push across surgery departments, specifically here at University of Chicago, to be have an effort to be more inclusive and to have more diversity, and to realize that there is other areas of research that are not your typical bench science, translational science, where somebody could develop an expertise and become a professor. So I think we are becoming a more inclusive discipline, surgery as a whole. And I think in the next 20 years, you're going to see more, diverse departments with more women, more minorities, more people in leadership roles than we traditionally have seen in the past.
Yeah, it's sort of a chicken and egg problem, right? So if when you go through the education system, if your expectations are, and I'm thinking about females here, if your expectations are that when you have a family, it's going to interfere with your progression in certain disciplines, you're going to undervalue those disciplines. Right. So the real question is, where do you start? Because if the status quo continues, you're going to get less female participation because they can look forward and see what's going to happen.
Yeah.
And so it has to be some sort of a systemic change that is going to sort of touch education as well as practice together, right?
Right. No, I agree with that. I think the specialty has to change. It has to revamp, and you have to reach out to women early during medical school and expose them to urology and and surgical fields and they need to see mentors. They need to have role models. So they need to see faculty who are 10 years in the future so that they can see themselves in those faculty members and realize that you can be in that situation within 10 years. You can have a family, you can have a meaningful, productive career in academics. That's why there's such a big push to recruit female faculty at all across institutions. I mean, we have one female faculty member, and I wish we had more, but I think in time we are going to have more. And again, urology is going to be the last to change because, of course, 50% of what we do is only on men, and so that's why our demographic has been such. But bladder cancer and kidney cancer can affect women as well, and all of our other voiding dysfunction and those things, stones, they can affect women. So a large part of what we do as urologists do involve women, but I think we are one of the few specialties that has been really male dominated, and so but we are already seeing a change. I want to say the statistics show us about 30 to 50% of current urology trainees are women. So we are moving in the right direction. And I would say if we do your podcast in 20 years, it'll be a lot different.
Excellent. Yeah, let's hope the change continues.
Yeah.
So this has been great, Piyush. Thanks so much for spending time with me.
My pleasure. Thank you so much. And I hope your subscribers find this educational and entertaining at the same time.
Absolutely. Thank you.
All right. Take care. Bye-bye.
Bye.